Kristen Honey, who is the Chief Data Scientist at the Department of Health and Human Services, as well as Ben Cushing, who is the Federal Healthcare Practice Lead at Red Hat, for a panel discussion on how federal agencies and their industry partners responded to the COVID-19 pandemic through data sharing and the development of applications and screening tools to prevent the spread of the virus and keep both healthcare workers and the American public safe. As a heads up for our audience, we also have an illustrator sketch noting today's event. So you will see drawings throughout the next couple of panels alongside a written transcription of the discussion. And just again, want to say thank you to Dr. Califano, Kristen, and Ben for joining us today.
Welcome.
I want to start out with kind of an opening question for Dr. Califano. And VHA is the largest integrated healthcare network in the entirety of the US and has a pretty substantial responsibility for both healthcare and medical research. And what I'm curious about is, how did VA first respond to the social distancing precautions at the start of the pandemic? Namely, how did VHA work to ensure healthcare workers remain safe and were able to quickly screen for, say, possible COVID-19 exposure when they're working in triage?
Great question. And I think when we think back to when this all first started, it seems like a lifetime ago, when it was still novel coronavirus. So we had a great team from across VA, from leadership to the front lines, all hands on deck. We are, as you mentioned, the largest integrated healthcare system. So a lot of talent, a lot of shared ideas. And we're focused on mission, not profit. So that gave us a lot of flexibility to act quickly. To keep folks safe, we started doing what we could. And at the time, that was just NPIs, which are non-pharmaceutical interventions. That's distancing, which we all know well now. And they're super simple, low tech, and they work. And at the time, that was what we had. So the concepts were simple: keeping the infected from the uninfected, limit the number of people in our facilities, and maximizing virtual care and virtual work options. VA was at an advantage because we had platforms already in place to do virtual visits. I do some primary care at our VA in Durham, and we were trained, all of us, on our video Connect platform ahead of time. Under modernization, we already had the setup to deliver care virtually, but it wasn't the norm for most of our visits. So there was a big learning curve. But the systems were there. I think we've now really come to understand the advantages there beyond COVID for that accessibility and that different kind of connection, meeting patients in their homes. So the first step, again, was distancing, getting folks, keeping infected away from uninfected. We also wanted our staff to be at home if they didn't need to be there in person. So that meant large numbers of people moving to telework very quickly. In the first week that we did that, we, were going on the VPN off peak hours. And it was about within a week after stress testing that we were all back up and able to come on the network at the same time. Again, all hands on deck for the effort. And we also did things for, once folks got into the facilities, like changing the way our medical kiosks, which at the time were the first checkpoint when people entered, how those were engineered to ask questions about, at the time, coronavirus exposures and symptoms, so that we could make sure they had a mask on them right away if they had symptoms. This was obviously before we were all masking. And then in about March, we moved to symptom screening at every entry point and controlled entry. And new tools came out of that as well. We had simple questionnaires to get your go screen to pass into facilities to make sure folks were symptom free when they were coming in, and to keep that flow so people could keep coming to work. So again, it does seem like a lifetime ago, but there was so much moving at the same time, and people really stood up to make it happen.
Absolutely. And it sounds like that was really momentous for ensuring pandemic safety and for keeping a lot of, frontline responders safe. And as another question about the initial response to the pandemic, one of the really substantial projects that has really helped American public health as a whole, I want to ask Kristen, it looks like HHS worked really substantially with federal agencies to mobilize data sharing at the start of COVID, both in terms of tracking the pandemic and coming to better understand the virus itself. How did that really come together, and how is that executed?
Yeah, thanks, Adam. Thanks for allowing me to be here and everyone watching.
It was a very complex thing, very multifaceted, of course, on how we did interagency data sharing, and beyond that, collecting data from all sectors, industry, academia, nonprofits, all of society, because as we know, COVID has affected all parts of our lives, not just health, but the economy, schools, everything. So how did it start? In the very beginning, we actually worked super closely with our VA colleagues and Department of Defense and Department of Energy. And one of the first things that we really did as an interagency group was to put massive amounts of data onto DOE supercomputers. The United States has some of the fastest computers in the world, and we were able to do agreements to get lots of electronic health records, really high value data on health and people who had COVID, people who didn't have COVID, to learn more about the virus and susceptibility. And that was all because of interagency data sharing, in collaboration across HHS, VA, DOD, and Department of Energy. And huge thanks to Oak Ridge National Lab for letting us use their supercomputers. From there, data sharing, the ecosystem that was built, a secure platform for ingesting all the COVID data, was stood up, and that's called HHS Protect. And very clearly, after that was stood up in April of 2020, we realized that we really need to be communicating with the public and be more and more transparent as we possibly can. And so soon after, we launched HHS Protect Public Data Hub, and then that's the public-facing visualizations and information. And then all of that data pushes to healthdata.gov and to data.gov. So that was sort of the arc. But the platform where we do a lot of the analysis, truly interagency, state governments use it, local governments use it, is called HHS Protect. And COVID response was a team sport. This was not HHS alone, but huge thanks to VA, DOD, everyone who was essential to the response.
Yeah, it sounds like that was really foundational in helping, best inform the public health response when the pandemic was first starting to break out, and as things clearly evolved. And I've got more of a technical question. This one for Ben. It's very clear that the COVID-19 pandemic put a unique level of stress on America's healthcare systems for managing, say, COVID-19 triage and those who need emergency care. And I'm kind of curious, how have AI capacities been used during the pandemic to better manage workflows in COVID wards and generally reduce the risk to healthcare providers?
Yeah, so one of the biggest challenges early on, and actually still today, is scheduling inside of a COVID ward. So you have, the patients and the providers working in a really dynamic environment, and the providers themselves are also becoming patients a lot of times because the virus is very virulent. So the outcome of that is that you need to change your scheduling behavior, right? Usually a schedule gets assembled over a few days, so usually 3 to 4 days to put out a schedule for the next month. And that, of course, changes rapidly when you have the workforce itself getting sick and not being able to come in. And so this is an area where AI is actually really suited because all the constraints are known. And so you should be able to reschedule all of this in a rapid pace. And that's something we went ahead and piloted, and we're able to actually turn around a full hospital schedule within less than an hour, and that's a huge improvement over what it takes now to actually bring on new providers rapidly, especially take advantage of like a remote workforce as well.
Yeah, absolutely. And I can only imagine how useful that level of speed and efficiency too was in this like really high demand, high stress public health situation. I want to kind of backtrack a little bit, and this one is for Kristen, and it's about, again, HHS's really forefront role in collecting and standardizing data. And from my understanding, we, as the pandemic progressed, there was a lot of interest and a need for, say, tracking sort of positive COVID tests, and for generally taking inputs not just from hospitals, but from field testing kits. And I'm kind of curious, how did HHS take a forefront role in kind of standardizing this COVID data sharing, including and especially as drawn from, say, various field testing kits that might not be used in hospitals?
Yeah, thanks. So as folks probably remember, in early 2020, when COVID first hit, it was really hard to get a test. If you got sick, To get a COVID test initially, you had to go to a hospital or what we call a laboratory setting, their lab tests. And then as the pandemic went on, tests became more and more available, especially the 15-minute rapid test or the antigen test. So as the pandemic went on, the volume of tests that were happening outside of a laboratory testing situation was growing. And we have really good plumbing for ingesting data and routing it to the states or to CDC and HHS for laboratory settings. If you go to the doctor, hospital, any lab setting, that data gets to public health authorities who need to know that information. But these non-lab testing kits and being done in schools, nursing homes, the drive-through, parking lots were converted to testing centers. How do we capture that data? So that was an all hands on deck, and a lot of that work is being done now with CDC modernization initiatives. Initially, one of the ways that we did it was to put out data standards. And so we realized, wow, if FDA is approving more diagnostic tests, more things coming on the market, we need to get ahead of this. And we need to say, what are the required data elements and what should manufacturers build for? Because you can imagine the next generation of tests could be automated. And if it's part of the test for you to get your results, is electronic, then you could imagine that an electronic positive, negative, indeterminate, timestamp, and geolocation, totally anonymous, could go back to public health. Technology could do all the reporting and alleviate, or at least largely minimize the reporting burden that we definitely did not want to ask frontline workers already burdened to report. So we're working on ingesting all of that, but recognize after putting out the data standards for non-lab tests, what the information we wanted for public health, the data standards are only as good as their adoption. If industry and manufacturers don't build for that, what good are the data standards? Or if they interpret it really different ways, so they, apply the data standards, then you have problems with interoperability and really scaling, and you need that for, good data insights and enabling emerging technologies like AI. So what we did there was we put out a call to the public, and we said to all of the world, we want your help. Here are our data elements for non-lab tests. How can we improve the data collection, ingestion, harmonization, and secure routing to where it needs to go so we can empower frontline workers and people on the ground who need to know the information relevant to them. We open up a crowdsourcing platform. You can check it out on Crowdicity. The URL is waters.crowdicity.com, the WATERS.crowdicity.com. We thought maybe 100 people will engage. Maybe we get like 10 submissions. We had over 700 people join. They formed teams. They submitted over 30 capstone projects of how they would tackle this non-lab diagnostic complexity. And so then we did a second phase of this innovation sprint. The first phase of innovation sprint that I just described was called a COVID-19 Diagnostic Designathon, or At Anywhere Diagnostics Designathon. And phase 2 of the Designathon was a full build technology sprint. And we worked with 12 industry teams, and they fully built out their proposed solutions. And you've probably heard about some of those teams because they're on the market today. So for example, IBM was one of our teams, and they built a digital health path. LifePoint was another one, an aggregator, getting a lot of these at-home tests and the non-lab tests ingested, aggregated, and now that plumbing to federal government exists. So those are some of the ways that we kind of early on developed data standards, put a spotlight on the problem, a call to action to all America, industry, and society to help us build digital tools to ingest as much data as possible.
Yeah, that's really impressive. And it sounds like you brought a lot of really sharp, knowledgeable folks, both from clearly within government, but also clearly volunteers and from the private sector to kind of aggregate this level of expertise. And it sounds like really streamline and improve the overall nationwide public health response. And it's fortunate that we're at a point in the pandemic where vaccines are widely available, which clearly represented a huge turning point for, containing the virus and for kind of bringing America kind of back to a place where we're able to manage COVID, I think, a bit even more easily than before. And this question is for Dr. Califano. And VA, from what I picked up, was especially quick in distributing vaccines to patients and to veterans. It sounds like VA has inoculated well over 2.5 million veterans at this point. How is VA able to coordinate and distribute vaccines so quickly and so effectively out the gate?
Well, that's a great question. There was so much planning that went into making sure that we maximize the distribution and spread of vaccines. And our biggest concern up front, as you remember, the vaccines initially had really stringent storage and handling requirements. And we wanted to make sure that when we were distributing them, we were not only getting them across the United States, but also doing it in a way that was equitable and maximizing access to all of our patients. Again, there were specific transport and timing, dilution, use within 6 hours. Because we are an integrated healthcare system, we were able to purchase freezers to be able to store the ultra cold vaccine products. And we worked with our VA leaders across the country to make sure that we sent the same number to each large catchment area. And so the first vaccine had large minimum orders that was primarily sent to larger urban centers with enough staff and patients to use it quickly. The next vaccine that came still had strict requirements, but smaller minimum order sizes, so we could get more vaccine out to smaller areas, more rural areas, and send it to, again, places with smaller numbers of staff and veterans. But we already have eyes on VA individual sites and VA across the nation. So we were able to really work together to plan that out. And I should also say we had great help from our partners, from our other federal partners, and even community partners. Everyone was trying to work together to make sure that folks were protected as quickly as possible with vaccine.
Yeah, absolutely. And I'm impressed by the focus on equitability and equitability of access to vaccines that VA is really emphasized as a core part of your program there. And I kind of want to ask a follow-up question to that as well, because obviously the logistical steps are essential and vital to have that foundation to provide a nationwide vaccine program. But it also sounds like a really big effort has been to kind of spread awareness of vaccine availability. And I'm kind of curious, how has VA helped, again, spread awareness of vaccine availability, but also potentially counter vaccine misinformation among the general public?
I'm glad you asked that. So again, most of this is through partnerships. People do not live in hospitals, they live in the community. CDC had such great information out. We were working closely with HHS, we were working closely with federal partners and community health departments as well. As you remember, we had more demand than supply early on. And so a lot of the communications up front were, when will it be my turn? And a lot of it was just geared at maximizing transparency, decreasing some of the nervousness of will you call me when it's my turn? We had a tool set up called Stay Informed or Keep Me Informed, where folks could sign up, express that they were interested in getting the vaccine, and then know that, that they would be contacted and get a little bit of information on the vaccines and when they might hear from us. On the back end of that, we had an outreach tool that let us look at patients that were at the highest risk, folks in older age groups, folks with medical conditions, and know who we needed to contact first and who we needed to make sure had protection first. We used vet text, which is a text messaging system widely to contact folks when they could schedule. And we also have a lot of folks who are more analog than digital, so we use traditional mailing campaigns as well. On the myths piece, that's been a really grueling part of the pandemic. There's so much misinformation. We have social media now, and I'd say the myth machine is rather astounding and deadly to our patients. VA is uniquely situated in that we provide care already to our veterans, so there's some trust built. We started out with listening sessions with our veterans, particularly focused on some of our outreach offices that served focused audiences, including minorities, women, tribal and rural veterans. So the first thing we did was try to listen to see what would help you make the decision to be vaccinated. And the message that we heard again and again is hearing from your personal provider one-to-one was the most important. So we did work on scripting and education to support that. But again, people don't live in the hospital, they live in communities. So we also are on social media. We have our VA sites, our Vantage Point blog. We have everything again in print form as well. And the myths really do come in waves. One of the most common things I think that we're handling throughout is mostly solid questions. This happened really quickly. I'm not sure what to think about it. These are the first vaccines of their kind in broad use, and so people had a lot of questions around that. And we know that we've been working on these vaccines and that this particular type of vaccine, the viral vector vaccines, the mRNA vaccines, these have always been uniquely suited to fight a pandemic. We've been watching this technology since the 1990s, but it's really hard to help folks come to understand that information quickly when they're also being bombarded with information on all fronts and they're dealing with the stressors of the pandemic. And again, we relied a lot on community partners, health departments, CDC, and other folks to help get that message as broadly as we could.
Absolutely. And it's such a vital message to get out there too, because again, we're still at a point where we do need to have more Americans, seek the vaccine and, protect themselves and their community. And it's kind of a follow-up to that question. I have a question for Ben, and it looks like, of course, we are dealing with a pandemic that has considerably stressed U.S. healthcare and providers. And even at this point, with the availability of the vaccine, we still do have regions where they are dealing with a considerable amount of COVID patients seeking and needing emergency care. And from the technical end of things, how has automation and automated technologies really helped alleviate this demand for hospital networks and other providers? How has that kind of helped, say, schedule and manage things over the past year and a half?
Yeah, two parts. I would say both the practice that's going on at the hospital, as well as, getting early detection done. So I'd just like to highlight like HCA Healthcare, for instance. It's an integrated healthcare network in the private sector that is using AI to find sepsis among their cohorts. And they're doing it 20 hours before the providers would normally notice something like that. That sort of emergent condition situational awareness is having a big impact on reducing the cost burden, but also improving the quality of the care that folks are receiving. That's having I would say that level of thinking is being extended to COVID and other disease states that are time sensitive. So like, pulmonary embolism, stroke, et cetera. I think that's a big area where we're going to start to see technology become another tool in the tool bag of the doctors to really, help get them answers faster. And then the other side of it is process automation, which, really means understanding the process and workflow that people are engaged in, and then codifying that into models that can be run and actually deliver tasks to individuals. And the real benefit to that overall is how that changes a healthcare system away from like a static 17-year cycle for learning to a learning health system that's engaged with new knowledge. So for instance, new knowledge coming out of CDC or NIH, those practices and protocols can be codified, right? And then if you already have a system that's running a process, you can actually deliver those processes directly into that system and actually affect care much more rapidly and train your staff a lot faster. The current challenge is the 17-year training cycle that happens inside of most healthcare organizations in the world. And this kind of approach cuts that down to like 6 months. That's a big deal. It lets us adapt faster to pandemics. there might be more. And we'd like to be able to move faster with knowledge as it's being produced rapidly within research facilities.
Yeah, that sounds like it's been a real advance and a real asset for American both healthcare and public health as a whole, really setting a foundation, as you mentioned, for, heaven forbid, future pandemics, let alone responding to this one. And I want to backtrack a little bit. Kristen, you'd mentioned that HHS has collaborated pretty closely with industry, and you'd mentioned, for example, I think work with IBM on IBM Passport. I'm curious if you could go into a bit more detail about the most substantial, or what you see as the most impactful work that HHS has done with industry so far?
Yeah, there's so many examples. So rather than giving one project or one company, I want to highlight the process that we use. And this process is something any agency out there can adopt. It's modeled, it came from the Obama White House, and they called it the Opportunity Project, or TOP for short. And the idea was, instead of doing a hackathon for a day or a weekend where there's a lot of energy, great ideas, but then often it goes nowhere from there, the idea was, could we do a 3-month sprint and create value from open data? Real world values have an impact from federal data. And it was a sustained engagement. And the federal government would provide the data, access to the data stewards, and the lightweight process for collaboration, where industry teams who are building digital tools, creating value from the federal data, could ask questions, get clarification. And in that really fast build cycle, industry would produce new digital tools or new functionality in existing digital tools to solve problems that were important to the community out there in the real world. And long term, all of those tools are maintained by industry outside of government. So that model ended up being so successful that it moved over to the Census Bureau over in the Department of Commerce. And you could find the top playbook online. We condensed that to do a mini version, a condensed version. So the build cycle was faster, and we did it all in the open. So all of our demos were completely in the open, office hours, all that defaulted to radical transparency, because we wanted to demystify how we were working with industry and how HHS was operating, and build trust through transparency. So we took that, did our COVID-19 tech sprint, and a dozen digital tools came out. So that's what I'd recommend in terms of what was some of our impact. It was more the process than any one project.
Absolutely. And it sounds like it's, again, both laid the groundwork for a lot of really substantial work so far, and really will help bring those kind of collaborations forward in the future. We are kind of running a bit close to the end, but I want to ask a question here for Ben before our time wraps up. And that's a general question about information privacy and security, because there's clearly been a lot of data sharing, a lot of sharing of public health data and of health data in general that has gone into addressing the pandemic and informing the public health response. But as that has developed and continued, how have both private industry and government kind of reconciled this need to access and share large quantities of data with upholding patient privacy and information security?
That's a loaded question. I would say that the traditional methods for sharing data are still in place. So of course everyone's following HIPAA, and there are challenges with that. I mean, there's a benefit to the privacy, right? That's why we have it. But it is a direct challenge to create new knowledge from data that is synthesized. So there's always a desire to use as much of the data as possible without compromising anyone's privacy. I would say one of the technology advances that's on the horizon that's going to make a big difference in this is edge computing. And the whole purpose of that is to deploy models directly to an edge device where the actual data can reside. So you have right to know within that edge space, and you can do a lot of your inferencing and research there. And that actual edge device is managed by separate systems that might be in the cloud in a more exposed space, but the data is not residing there or going to that direction. So in that way, you can actually create physical isolation of the data and continue to get the insights that you're looking for.
Absolutely. And of course, it is a bit of a tricky question, but that does sound like a really promising way of kind of upholding that. And again, unfortunately, our time has about wrapped up, but I want to thank you, Ben, Dr. Califano, Kristen, thank you so much for joining us and sharing your insights.
You're welcome. Thank you.
Thanks so much.
Thank you.